and we're going to be talking with Joseph Friedman today. Dr. Friedman is a neurologist. He is the chief of Butler Hospital's Movement Disorders Program. He's a professor and chief of the Division of Movement Disorders in the Department of Neurology at the Warren Albert Medical School at Brown University. And he is an active member of the Parkinson Huntington study groups, and he participates in multiple trials sponsored by NIH. He's been on our programs before. He's talked about fatigue before. You might have seen that on our YouTube channel. Today, we're going to be talking about tackling the tough symptoms. And these are the things that are a part of Parkinson's, but may not necessarily be as easy to address with medications. He's going to give us a wonderful overview of what those are, how they might present, why they're a challenge, and give us some insights. And so I'm going to welcome Dr. Friedman.
Thank you.
And hand this over to you.
I just put share and nothing happened.
Okay, so I think the last time you practiced it was an extra button, share screen. Does it give you an option to click the screen?
There, and there's share screen, and I think you're right. And there we are, right?
Voila, you have it.
Okay. So I was asked to talk about tough problems in Parkinson's disease, and I asked Anissa if she could be a little more specific, and she made it basically tough problems on the behavioral side of Parkinson's disease. We all know that Parkinson's disease is considered a movement disorder, and I consider myself a movement disorder neurologist. That is, I specialize in disorders of movement, of which Parkinson's disease is the one I see most commonly. And it's taken a long time before doctors, even in the field, recognize the importance of behavioral problems in Parkinson's disease, that although we define Parkinson's disease as a movement disorder, there are a number of behavioral problems that are extremely important in determining quality of life for people in Parkinson's disease. And this has been my overriding interest in Parkinson's on the research end of Parkinson's disease, basically shortly after I started my career a long, long time ago. So the first question, or the second question, I guess, after Anissa told me what to focus on, that is, that I should focus on behavior, is I had to ask myself, what does she mean by a tough problem? And the more I thought about it, the more I came up with the definition that a tough problem is whatever problem you have. That's a tough problem, because if it wasn't, it wouldn't be a problem. In general, I've listed a number of the important behavioral problems that unfortunately bedevil our patients with Parkinson's disease. And I'm sure I left out a few, but I can't cover everything in 45 minutes. But what turned out to be important and really so surprising for especially older doctors like myself is to look back over the long number of years that our predecessors had in taking care of and trying to treat people with Parkinson's disease, how little importance they attached to these sorts of problems, which turn out to affect, in general, probably about 90% of patients eventually. And not only are they common, but that they are often the major determinants in quality of life. So these are very important issues. And we've learned that although doctors in the last several years, the last decade or two, neurologists in particular, are better educated about Parkinson's disease and the many facets that Parkinson patients, what the kind of problems that Parkinson patients experience, Yet very often we learn from patients that their doctors don't always ask about these problems. And if patients aren't sophisticated like all of you are, you're all participating in this, trying to learn more about Parkinson's disease. But there are a lot of patients who aren't aware that there are major sources of information about it. And of course, there are lots of patients, especially newly diagnosed patients, who really don't want to know about too many things about Parkinson's, out of a very understandable concern for what the future might have for them. So I've listed the ones here, not in any particular order, except the first one really is the most important, I think, which is dementia. But I will try to cover these other topics as well. Obviously, not much time on any one of these, although each one of these could be a whole session. And in fact, I spent a whole session talking about fatigue several months ago. So dementia, anxiety, depression, fatigue, psychotic symptoms, by which we mean typically hallucinations and delusions, and I'll explain what those are, apathy, compulsivity, you may have heard of impulse control disorders, and a variety of sleep disorders. And as I said, each of these could be the subject of a whole session, and each of these have been the subjects of rather lengthy review articles, just focused on one of these particular problems at a time. So dementia, you've all heard of dementia. Mostly in the newspapers, when you read about dementia, you read about Alzheimer's disease, because that's a much more common disorder than Parkinson's disease. And so it attracts a lot more attention. More people have it than have Parkinson's, so their family networks are much larger. So it's of great concern. Plus, there are a lot of changes that take place with normal aging that make a lot of people worry that they are developing dementia, which is not so common for people to think that they have or about to develop Parkinson's. So what is dementia? We often talk about it as a memory disorder, but it really is much more than a memory disorder. Certainly, people who suffer from dementia have a decline in their memory. I would guess that most, or certainly many, of the people who are listening today have experienced the problem with word finding. They're in the middle of a sentence and they can't get out the word, and they know the word, and it's a particular word that has a particular meaning, and they can't think of it. It happens to us all. We all forget things. We misplace things. Some people misplace things more than others. But a decline in your memory, a decline that results in some change in your life. You know, we all forget names, at least the older ones among us, including myself. We forget names, we forget words, but generally they come to us. They may come to us a minute or two too late to be useful when we're meeting somebody, but nevertheless, they come back to you. So there's decline in memory, but there also are declines in various cognitive skills. Demented people are less good at problem solving. They may not be able to solve problems like how to fix something that went wrong in their house, how to drive from one place to another if there's a roadblock somewhere, a challenge in daily life, which they normally would have handled without thinking too much about it, they might now be stumped by. They may develop more of a language function than simply forgetting the occasional word that they need to complete a sentence, but they're forgetting names of things, maybe common objects, like they can't remember the name of a spoon, and then they remember it later on, but it becomes more common than we consider normal. They may lose some of their math skills. They can't do, they can't do simple arithmetic. They can't figure out how much tip to give somebody at a restaurant, which used to not be a problem for them. Now it is. They may have difficulty interpreting things that are going on around them or understanding a complicated plot in a movie or a TV show. Their concentration may become impaired. They may have difficulties with planning, with multitasking. And this can happen in Parkinson's disease. Unfortunately, it happens more obviously than we would like, but it may happen. Typically, in Parkinson's, it occurs late. So unlike a related disorder that you've probably heard of called Lewy body dementia or dementia with Lewy bodies, in that disorder, dementia occurs early. That's the first or one of the first features that develops. Whereas in Parkinson's disease, of those patients who are destined to develop dementia, it usually occurs after they've had the illness for several years. It can be difficult to tell when people first start developing dementia because, as I mentioned earlier, there are changes that occur with aging that we consider normal. And so very often when a person tells me that they think they're losing their memory, I just ask them to compare themselves to their friends and relatives who are their age. Are they having more trouble word finding and thinking of names of their cousins or family or friends than their relatives and friends their age are? If not, then probably they're not demented, they're just getting old. It happens to me all the time. In addition to dementia, there's an issue that really is very rarely discussed, which is something we call pseudo dementia. Pseudo means false. So there are people who sometimes seem demented, that is, they have memory impairment as a result of something else. So hopefully you can see this clock. The task I gave the patient was a circle that was empty, and I asked the patient to fill in the numbers to make it look like the face of a clock. The top was the first attempt. When that person had difficulty with it, I drew another circle below and asked them to try a second time because the patient realized that there was a problem. But this patient was extremely anxious. It was the first meeting we had had, and she obviously was very worried about what I might tell her. And even though she hadn't had memory or thinking problems, when I asked her to do this task and I drew this clock, there's obviously a major problem. And so people can have memory and thinking problems due to other problems. So for example, you probably always advised your children or grandchildren that they should get a good night's sleep before they take a big test at school in the morning. And that's because we all think better when we've had a good night's sleep. So if you're sleep deprived, you're not going to do so well on a test. You're not going to do so well in the doctor's office or on neuropsychological tests. There are a number of other things that can interfere with your thinking and your memory. For example, depression, or in this case, it was anxiety. You can think of anxiety, depression, chronic pain like headaches or chronic low back pain as problems that interfere with your concentration. If something interferes with your ability to concentrate, you're not going to pay attention. When people tell you what time your doctor's appointment is, what time you need to meet them for a social event, and you're in pain, you're not registering that information well. So you may ask about it again and again, and you may keep forgetting. And all of those things, depression, anxiety, pain, sleep deprivation, all of them can interfere with your ability to remember, to process information, to plan. They all can produce an effect that's very similar to dementia. And because many of these problems, like depression and pain, may be very long-standing, they can be difficult to tease out. So it's something to keep in mind when you start worrying yourself about your own mental state. You've all heard about depression in Parkinson's disease. And when I was in training, this was the only behavioral problem that anybody talked about when they talked about anything related to Parkinson's that wasn't restricted to tremor, walking problems, balance, and other motor capabilities. Depression is very common in Parkinson's disease, and it can be very difficult to diagnose. So the question becomes, what is depression in Parkinson's disease? And the answer is, it's a sense of persistent sadness. It's a problem with getting pleasure out of things that ordinarily or used to provide pleasure. It's often a sense of irritability, that people bother you much more easily, or you lose your temper more than you used to do. But in Parkinson's disease, it can be difficult to evaluate. When most of us on a routine basis see somebody and we get the feeling that they're depressed, how do we get that feeling? Well, usually it's partly from their facial expression. They look depressed. You know, my brother James looks depressed. Very often people with Parkinson's, because of their reduced facial expression, may look depressed to some people. I had a patient many years ago who told me that his single worst problem in Parkinson's was that people thought he was depressed when he wasn't. It was his facial expression. I mean, that's not a common symptom to be number one, but nevertheless, for him, it was. So people often think other people are depressed based on their facial expression. It could be on their tone of voice, that they don't express themselves with the amount of variation in the musical tones in their speech. And people with Parkinson's are often very quiet. They can often be difficult to hear, and often they talk less because people have difficulty understanding them. So that can be misinterpreted as depression when it's not there. Plus, people with Parkinson's are often grieving. They can't do the things they were expecting to be able to do when they got to a certain age. They are frustrated because they can't engage in their old hobbies. They get angry that they are perhaps somewhat impaired, and that they feel they may have been robbed of their golden years, as people often describe retirement years. Anxiety. Now, anxiety is a really tough problem, okay? And the reason it's a tough problem is that it really creates difficulties, not only for the patient, because it's extremely uncomfortable to be anxious all the time, but it also creates problems for family members, because people with anxiety, because of their anxiety, they often require attention. They may ask things over and over again. They may complain about things more than other people. And when I looked up a definition of the psychiatric definition for anxiety in DSM, which is the Diagnostic and Statistical Manual, which is the psychiatric Bible for diagnosing, they defined anxiety as excessive worry, which occurred on more days than not. That means more days are days with anxiety than days without anxiety, that the anxiety is difficult to control. We all have anxiety. We all have things to worry about. There's nobody who has nothing to worry about. You're always worried about the health of your relatives, the health of your friends, your own health, whether you're going to be able to do something, whether you're going to be on time, whether your friends are going to be on time, what the weather's going to be like. I mean, there's an infinite number of things to be anxious about. There's always something to worry about, but you can usually control that. You don't, go berserk because there's a threat of rain. You might get anxious if there's a threat of flood, but that's an entirely different sort of problem. So in addition to having anxiety most of the time, and the anxiety can sometimes be difficult to control, so it simmers over and affects your interactions with other people. They also require 3 of the following 6 symptoms, which is feeling restless or keyed up or on edge, that you fatigue very easily, that you have difficulty concentrating or your mind goes blank. And I mentioned, I just underscore that this is something I talked about earlier when I talked about pseudo dementia. Irritability, you have muscle tension and difficulty sleeping because you worry, and the worry interferes with your ability to fall asleep. Psychotic symptoms, and the next slide is going to show you, or you'll hear somebody talking about psychotic symptoms. Psychotic symptoms in Parkinson's disease fall into three major categories: hallucinations, delusions, and illusions. The sense of presence I'll get to in a minute. A hallucination is a sensory input for which there's no stimulus. So we have, each of us, 5 special senses. We see things, we hear things, we feel things, we smell things, and we taste things. In people with primary psychotic disorders, that is, psychiatric psychotic disorders like schizophrenia, or sometimes major depression, or a severe case of bipolar disease, patients may have hallucinations, and they're typically auditory. That means they're typically something that's heard. They hear voices typically, and the voices usually say things that are unpleasant. They'll say that everybody hates you, that you are ugly, that you're fat, that you smell bad, that your clothes are terrible, you have poor taste. It's uncommon for people to have visual hallucinations. Visual hallucinations, that is, seeing things that are not there, are much more common as a drug side effect. Virtually all drugs that may cause hallucinations, including things that people took to get high, like magic mushrooms or LSD, they cause visual hallucinations, typically. And the Parkinson medicines also typically cause visual hallucinations, and they're surprisingly common. So I try to ask every patient at every visit whether they've had hallucinations. And the reason I ask is twofold. One is, if they're having them, I'd like to know, because I need to reassure the patients that this is a medicine side effect, and I need to know about it, because if I give them more medicine, it's going to get worse. The other reason for asking about it is that it's a common symptom, and people won't volunteer that because they're afraid other people might think they're crazy in some way. And by asking about it when they don't have it, if it does occur, and it occurs in about 20 to 30% of people who take Parkinson medicines, if it does occur, they'll say, oh, that's what Friedman was asking about. And they'll know that it's benign, that it's from their medicines, they're not going crazy, and it gives them something to talk about at the next visit. So it becomes much less threatening than if somebody doesn't know this can happen. They're sitting in their room watching TV, and suddenly there's this little kid sitting on the sofa next to them who doesn't talk to them and ignores them. So hallucinations are fairly common in drug-treated patients. They occur in about 20 to 30% of patients, which is a very large number. Delusions are different. A delusion is an irrational, false belief that is not based on data. And unlike hallucinations, which usually, not always, but usually are benign, where you see a person sitting in your room watching TV, reading a book, playing games on the floor, maybe even a statue just there. Delusions tend to be paranoid in nature in general. So a delusion is an irrational belief. You think people are living in your house who don't belong there. You think that your spouse is cheating on you. That turns out to be a fairly common one, both men worried about their wives and wives worried about their husbands, that people are stealing from you, that the mafia is after your children, things that are irrational, but are unshakable beliefs. And so those are almost always very serious and need to be taken very seriously. Hallucinations need to be known about, but they don't necessarily need to be treated. But delusions, because of their paranoid nature, always makes people feel uncomfortable. And if you're uncomfortable and you may feel helpless, if you have bad Parkinson's disease, it's really a terrible situation to be in. The sense of presence is really more of a peculiar thing because it's such a rare thing outside of Parkinson's disease, where people feel that there's someone else in the room with them, but out of view. So there's somebody to the side or behind them, and they turn around and there's nobody there. And we all get that from time to time. And it may be a feeling that there's an animal there, but it's never threatening. It's never someone who's about to harm you. It's never a dog that's about to attack you. It's always something benign, and you don't know what it is, or you may think you know what it is, but it's never really there. And as I said, we all feel that from time to time, but this becomes a more compelling and frequent kind of perception. So here's a man describing his hallucinations.
Thank you for upper in action on the ceiling.
Oh, let me get that back. I'm sorry.
Thank you for agreeing to let me show this video to other health professionals. Can you talk about the hallucinations? When I was on the amantadine. Well, that would be sure. Yeah. I saw the Last Supper in action on the ceiling. I had a man with wings fly through the room. I jumped out of bed and. Well, that's a different thing. Oh, okay. So we won't talk about that now. Okay. I hear classical music. I hear people knocking on the door. I get up and answer the door, but nobody's there. And that's still happening? That happens periodically. Okay. Now, when you saw the Last Supper. Yes. Or when you saw the man with wings. Yes. Had you been sleeping? Or had it occurred while you were fully awake? When I was sleeping, I woke up. And you've experienced that? Yes. Have you ever seen things when you were fully awake? Yes. Can you describe those things? Well, I don't recall exactly, but like I was awake when I saw the man with the wings. Okay. I woke up from sleep. And how did that make you feel? It didn't bother me because I knew it was not real. Was it kind of like watching television? Yeah, just like watching television. So it was a little bit. And it was in color. It was in color. And did you speak to the thing? No, I didn't have a conversation. And I just watched it. And how long was it there? Couple of minutes. Okay. And then when it disappeared by itself, or you did something to make it disappear? I just knew it wasn't real, so I turned over to go back to sleep. Okay, and then it disappeared. Yeah. Okay. Well, thank you very much. You're welcome.
So this is different than hallucinations that you see in movies, right? And this is really such an extraordinary sort of thing that here's a person, intelligent, cognitively intact person, who wakes up, he's fully awake, he sees a man with wings flying in his room, he watches it for 2 minutes, thinks to himself, this is a hallucination, and just goes back to sleep. It's, if you think about that, it's rather an extraordinary sort of thing. And the hallucinations vary enormously. Most of them are less fantastic than this. Most of them are, as I mentioned before, people sitting on a chair, watching you, reading a book, watching TV. They usually ignore you. You talk to them, they don't pay any attention. And it's as if you're a hallucination to them. That sometimes gets people upset that this person ignores them. Sometimes the people look unusual, like they may not have a face. or they may have funny noses or wear funny clothes. And they typically are the same ones every time. So I had a patient who had a baby visit every night, and he smiled and he said the baby was wonderful. He never made any noise. But the hallucinations can also be scary. You wouldn't like to wake up in the middle of the night and see some stranger at the foot of your bed, kind of lurking there, not doing anything necessarily, but who wants to see a stranger in their bedroom who looks very real. So hallucinations can be a problem or may not be a problem, but they should always be identified because, say, in this person's case, if he didn't tell me, I would have continued him on the amantadine, and over time, they would have slowly gotten worse. I might have increased other medicines or even increased his amantadine, which would have made them worse and might have caused him then to develop delusions, which, as I said, are always uncomfortable. Compulsive disorders, they're called ICDs, or impulse control disorders, which you may have read about. These are associated primarily with dopamine agonist drugs. Dopamine agonist drugs are drugs that are used for treating the motor symptoms of Parkinson's. They are pramipexole, which is Mirapex, rotigotine, which is the Nupro patch, and ropinirole, which is Requip. Some people may be on apomorphine, which is apokine. Those are dopamine agonists. That is, there are drugs that have chemical activity similar to dopamine. And it took many years, 20 years maybe, before it was recognized that these increase the risk of a person developing an impulse control disorder. And impulse control sounds like people get an impulse and they can't control it, but it's really more of a compulsive disorder. People have a chronic need to do something. And these somethings that they do are generally very specific for them. So the most common is gambling. And this is much more common in people who have a history of pathological gambling, but could occur in people who don't. There are people who become compulsive shoppers. And again, this is more common in people who had a history of shopping somewhat excessively before, but may occur in people who have never done this. People playing games, they start a computer game and they can't stop, and they'll stay up all night playing computer games, and yet they may not be doing anything else in a compulsive way. So there are people who develop a compulsive sexual need, people who collect things. I had a patient who collected uranium glass. He would go to flea markets all over the Northeast looking for uranium glass, people who start hoarding, and some of them that are very, very specific. So one of my colleagues, not myself, had a patient who gained 20 pounds eating one kind of apple. And when she stopped taking the medication, she stopped eating the apple. I had a patient who baked a cherry pie every night, and he told me that he didn't know why he did it. He didn't eat the cherry pies because he didn't particularly like cherry pies, but he felt compelled to do it. It's a remarkable sort of problem, as if you're being controlled by some force outside your body. And this can cause major trouble, especially gambling and sex. Most people don't complain too much about somebody who cleans too much, but gambling, I was involved as an expert witness in a lawsuit because of a claim that the doctor hadn't sufficiently warned the patient's family, and the patient had gambled away all the money that the spouse was expecting to use for a business venture, and there was a divorce. And, as you can imagine, it could be extremely, extremely unpleasant. I have a video which is too long to show you gambling, but I want to show you another one because this is the kind of thing that people don't recognize as abnormal, and it's not terribly abnormal at all. In this case, it might actually be good, but it's a change in behavior. So this is a man who developed an issue where once he started a chore, he couldn't stop, even though it didn't need to be completed right away.
So can you describe what you feel when you have a chore, something that breaks, say, in your house, and you need to fix it?
basically, if something breaks, I have to do it right away. The doorbell broke and I did it that there. Then the television wasn't working right, and I was up to 1 o'clock in the morning looking for the wires. And it was raining out, and we had to go outside to get to the basement. So 1 o'clock in the morning, I went outside, down the steps into the rain to get the wire. I went back upstairs again, and that wasn't right, I had to go back down again. But by 1:30, the television was working fine, and completed the project, but I just could not wait till the next day because it would have bothered me all night.
Okay. And you said that he used to be like that, but not nearly as much so. This is sort of an exaggeration of the way his personality was before the Parkinson's. Is that right?
Right.
Okay, thank you very much.
So here's a person who he'd start a task, and instead of saying, oh, it's midnight and it's raining outside, I'll finish it tomorrow, he couldn't stop. And this was typical of him at this time on his medicines. It wasn't anything terrible, but it represented a change. Fatigue. Fatigue is a very common problem. And as I mentioned before, I did a whole session on fatigue for PMD several months ago. It's surprisingly common in Parkinson's. It's very common across the spectrum of virtually all medical disorders. In Parkinson's disease, we discovered here in Rhode Island that it was one of the 3 most common symptoms affecting about 50% of my patients. And this is true around the world. So it's not a cultural thing. It's a feeling of weakness, severe lack of energy. The British patients say that they're knackered, and it goes hand in hand with a lack of motivation. And it has an unclear relationship with apathy, which I'll get to in a minute. So people with fatigue and Parkinson's have an excessive amount of fatigue. We all get fatigued. We all get tired. You run a marathon, you're fatigued. You clean the house all day, or you're lifting things, you get fatigued. You spend a lot of time studying something very hard, you may develop mental fatigue. Your kids drive you nuts, you may develop emotional fatigue. There are all sorts of fatigue, but fatigue in general, all of these types of fatigue are much more common and more severe. The patients who suffer from fatigue say it's unlike any fatigue they suffered previous to this. And it can be very hard for the family to understand because the fatigue does not seem to be related to how severe the Parkinson's is. So you see patients who have very severe Parkinson's, they have a lot of trouble walking, they're using a walker, they're very slow, and other people who walk almost normally, and the person who's walking normally has a lot of fatigue, and the person who can barely move because they're stiff and slow and they've had the disease for 25 years, they're not fatigued. So we don't understand it at all, but it's a major impediment to life.
Can you say that it's okay to use this interview in a presentation to patients or doctors?
Absolutely, certainly can use the video.
Thank you very much. Now, you told me that you were having a problem with fatigue. Can you describe that?
It's like a tiredness I've never felt before. It's just, you're very, very tired, but you're not sleepy. You can't take a nap. You just feel totally washed out.
How does that compare to, say, when before the Parkinson's and you did a lot of work? Say you were digging in your yard or you walked 10 miles or something?
That's kind of good fatigue. You feel tired, but not the same way with Parkinson's. It just wipes you out.
And say you needed to do something, say you were feeling wiped out and you needed to take care of some problem in the house, would you be able to do it?
I would, but it would take a big effort.
And is the fatigue there all the time, or it only comes towards the end of the day?
It comes it's not all the time, no. It's mostly towards the end of the day. or in the afternoon sometimes.
And if you rest, will it go away?
Doesn't seem to.
So once you're fatigued, you're kind of wasted for the rest of the day?
For a few hours anyway. Sometimes it goes away.
Do you ever try to push yourself during a time where you're fatigued? Do you ever?
Oh, yeah, I try all the time.
And what happens?
Well, I it's hard to say.
Do you sometimes get less fatigued if you exercise?
Yeah, I sometimes I try to do that when I'm feeling really tired. I'll get on the bike.
And that will help the fatigue?
I think so.
Okay, that's fine. Well, thank you very, very much for providing those insights.
You're welcome.
One of the interesting things about fatigue is in Parkinson's disease is very often patients will say that although it's very hard for them to get to exercise because they have this threshold or this hurdle that they have to surmount, that once they exercise, they actually feel less fatigued, which is very different than the general population that doesn't have Parkinson's disease. So apathy, I'm going to go quickly so that there's time for questions. So apathy is a very difficult problem to understand in Parkinson's. It's emotional blunting. People are not happy, they're not sad, they have very little in the way of emotional feelings or emotional expression. And that goes hand in hand with a lack of motivation. So there's a connection between apathy and motivation, and also with fatigue, that people who are fatigued, of course, don't have much in the way of motivation. Then you could say, well, if you're fatigued, how can you do anything? Because everything is hard because you're feeling tired all the time. But there's an uncertain relationship because there are people who have no motivation who aren't fatigued, but there's usually a strong connection between apathy, lack of feeling, and motivation. And this can be a very big problem for families because the spark in their loved one is no longer there. On the other hand, the person with the Parkinson's who's apathetic generally doesn't feel as terrible as their family feels for them because of their Parkinson's and the impairments that the Parkinson's has caused. The family feels the pain more than the patient appears to feel the pain. So this is apathy, and I mentioned this business about apathy having this somewhat silver lining that they're somewhat insulated. And I mentioned this in a talk that I gave, and somebody wrote to me from the audience. He's a 32-year-old man who was diagnosed at age 26, so that's unlike most of you in the audience. My physical symptoms, though a pain in the butt, a lot of the time are by no means disabling, nor even a little bit. I am not loath to do things because of the effort. There are times when I literally can't think of what to do, so I watch TV or sit quietly. I'm not bored, not upset, not sad, just sitting. There are times when I know of things that need to be done, but just don't do them. I can't tell you or anyone else why, I just don't. Then there are times when the apathy is very good, and I can and will do lots of things. So you can see the connection here between apathy and motivation. So there are things he has to do, but he won't do them because he doesn't feel like he wants to do them then. And yet there are other times when he can and he does. And he says when he's not apathetic, those are great days. He was having one now, enabling him to write this email, and so sharing his good day with me. So patients with these behavioral problems often fluctuate. You've heard of motor fluctuations where people take their medicine, they have a good response to the medicine, and then it wears off before their next dose. They take a medicine, they get better again, and then it wears off again. Some people have the on-off syndrome in which the medicine works for a while, and then unexpectedly, the medicine seems to stop working, and then it starts working again, and then it stops. So we call those motor fluctuations because the person's response to the medicine fluctuates throughout the day, sometimes in a way we can understand, sometimes in ways we don't understand, that can be somewhat random. Less common, but what's also been shown to occur is that some people will have non-motor fluctuations, will suffer emotional changes, usually related to the medicine, but not always. And these changes usually have to do with anxiety. So patients will go through the day and they'll have periods where they become very anxious and periods of time where they're not anxious. And this happens throughout the day. Sometimes it can be corrected by altering their medication schedule, sometimes by trying to treat the underlying problem, which is usually anxiety, but sometimes depression. Now, I missed one slide that I wanted to show you, which was this one. So a patient of mine came to the office last week wearing this T-shirt, and he didn't know I'd given a talk on fatigue. He didn't know I was going to use him. Next time he'll be the first slide instead of a slide with a lecture, with the name of the lecture. So I am finished, and I'll be happy to entertain any questions.
Awesome, thank you. And I do have a few questions, and I'm gonna I don't know if I can unshare your screen so we can
I'll
all
stop
see
sharing.
each other. Yeah, that's perfect. Okay, so I want to go back to some of the information you're discussing in regards to anxiety. So the first question is, the symptoms of anxiety overlap with some of the Parkinson's symptoms. So how do you tease out the difference?
You mean like the restlessness? So that's a very good question, because sometimes you can't. There's a syndrome that we usually see with patients who take antipsychotic drugs, which are drugs used primarily for schizophrenia or bipolar disorder, which block dopamine receptors. So they are sort of anti-dopaminergic drugs, and generally have as a side effect causing people to look like they have Parkinson's disease. But one of the features, one of the side effects that occurs in patients when they first start the drug is a problem called akathisia, which means not able to sit, where patients get this overwhelming urge to move. They feel extremely restless, and they sometimes experience that as anxiety. And it can be very difficult, evidently, for patients who have this feeling to distinguish anxiety from restlessness. And people with Parkinson's disease sometimes have akathisia. The first description of akathisia, in fact, was in a patient in the court of Napoleon III who had Parkinson's disease, and that was in the 1800s. So there were no drug treatments for it. So it can be very difficult, just like, you know, it's also difficult to distinguish depression from, you know, just not feeling good and having a masked facial expression, a soft voice, and fatigue and poor sleeping, because most people with Parkinson's have problems with sleeping. So anxiety really, you have to make a diagnosis of anxiety, the person really has to say that they feel nervous or anxious. Unlike depression, where you could say, well, they don't enjoy things, or they don't sleep well, or they're losing weight, or these other kinds of somatic problems, that is bodily sorts of problems. With anxiety, really, you need to have somebody who says they're nervous. They may ruminate, they may be thinking about a certain problem that they didn't invest enough money when they were younger in something or other. So now they don't have enough money, they can't afford their house, you know, and they ruminate and they think about this over and over and over again. But mostly they feel nervous. They're worried about something. So, you know, another word for anxiety would be worry. They worry about their children, their grandchildren, they worry about the weather, they worry about their house, they worry about their finances, whatever. I'm not, you know, restless and anxiety overlap and can be difficult to distinguish. But other than that, anxiety usually is, I think, fairly straightforward.
And while we are talking about tackling some of those tougher, behavioral neuropsychiatric issues, you can treat for anxiety and depression, correct? I mean, can you talk a little bit about the treatments, not only med, but maybe even like counseling or other supplemental things?
Yeah, that's actually a more complicated question than you might think. As far as I could make out, there's been only a single study looking at treating anxiety and Parkinson's disease in all these years. And that was a very, very small study. And the result was that the drug that they used caused too many side effects. There was a moderately large study done at treating depression. And that study actually had to stop prematurely because they couldn't recruit enough patients. In that study, the drugs were helpful, but really not very helpful. They weren't a lot better than placebo in treating anxiety. I think all of us who treat feel that these drugs are helpful, but there are very few data to support that. The trials that need to be done, especially in anxiety, but also in depression, really just there haven't been enough trials done to prove that treatment works. I think the treatment works, but not for everybody. And I think one of the problems that we doctors have is that we start a patient off on treatment for one of these problems. And once they start a drug, they never stop it, whether it works or not. And we need to be more cognizant of making sure that any drug we give does something positive for the patient, or we should stop it and try something different. If I have a patient with depression, I'll usually recommend that we treat them. And I will try to treat them even though the data is not as solid as I would like. And I hope that I stop the drug if it's not helpful and try something different.
So in regards to the gentleman that was sleeping and then woke up and he saw the winged, whatever it was, animal or person, can you talk a little bit about the difference between vivid dreaming and hallucinations? The line between the two, or?
Well, the line is easy to talk about. It may be more difficult for the patient to determine. So there's a major difference between vivid dreams and hallucinations. Vivid dreams are dreams. They occur while you are asleep. And if there was a sleep study being done while you were dreaming, they would see that your eyes were moving, that you'd have REM sleep, not REM sleep disorder, but REM sleep. And levodopa in particular makes people have more vivid, more realistic dreams. And they can be so realistic at times that people will wake up and think the dream really happened. Another issue that occurs is people who have these vivid dreams sometimes wake while the dream is still going on, and they will experience the dream as occurring while they're awake. That usually goes away within a minute or so. A hallucination is something that occurs when you're awake. You're fully awake, you're, say, reading a book, and then you see out of the side of vision that there are some people in your room. And you turn and look at them, and there they are. You see these people, but they're not really there. So a hallucination is something that you see or hear, mostly see, that's not there while you're awake. And the importance of distinguishing them is that hallucinations are something you might want to treat, whereas dreams you really can't treat. And usually dreams don't cause problems. They can, of course, if you have bad dreams. You really don't want bad dreams to be more realistic. You want to forget them before you wake up.
Absolutely. Is there a time of day that hallucinations tend to be more common? Are they?
Much more at night, much more at night. And that's when they cause more trouble, because a person wakes up in the middle of the night, they have to go to the bathroom to urinate, and they see 3 people in their bathroom. I mean, that's would cause distress in anybody.
So you mentioned that medications can increase hallucinations as well as impulse control disorders. So can that happen even if you're not taking a dopamine agonist? Can it happen with carbidopa, levodopa, or Sinemet?
Yeah, that's a tough question because, these sorts of problems do occur in the general population, but not so commonly. So there's I believe, a mild increase in Parkinson patients who take levodopa who are not taking dopamine agonists. But with dopamine agonists, it's much greater. It's about 10 to 14% of people who take dopamine agonists at the Parkinson doses who might develop this problem. It's much less common in people who take the same drugs for restless leg syndrome, because the doses there are much lower.
So is nail biting, which would be a lifelong habit, but becomes more excessive, considered an impulse control issue?
That's in the mind of the doctor, I think, or the patient, or the family. So for example, I have had a patient who started trimming his toenails. And he had never spent time trimming his toenails other than, I think, appropriately trimming his toenails. But now he couldn't stop trimming his toenails and he made his toes bleed because he was trimming his toenails all the time. That came out of the blue. He'd never done it before. So that's new. And we stopped the drug and it stopped doing that. In the case of a person who spent a lot of time trimming their nails, and now they're trimming their nails twice as much instead of every other day, they're doing it every day instead of once a week or however much time people do it. You'd have to decide, is it causing a problem or not? If they spent their whole day filing their nails, it's a problem. If they're doing it, 15 minutes and it doesn't interfere with their life or anybody else's life, then I probably, as long as it wasn't a danger, they weren't cutting themselves, bleeding, or doing something bad, I would say no. It's always a judgment call. Some of these disorders may not be so bad.
And when you were talking about, the different senses that can be impacted by hallucinations or strange feelings, there was a question, I don't know if it falls in that category, but is it possible to have symptoms such as vertigo or proprioception confusion with Parkinson's?
Not vertigo. Vertigo I would consider an inner ear problem until proven otherwise. And it's not part of Parkinson's disease. And what was the other one?
Proprioception confusion.
About proprioception difficulties. Well, people can have what are called tactile hallucinations. That is, they feel things. So after visual hallucinations, which are far and away the most common, we have auditory hallucinations, which are about half as common. And after that, uncommonly, but still well described, are tactile hallucinations. And the most common one I come across are people feeling things crawling on them. They're usually things like bugs, or they might be little animals like mice that are crawling on them. I had one patient who complained that in the middle of the night, that a person came into his room and poked him with a stick. Didn't hurt him, but it bothered him, of course, that this teenager was sort of molesting him for no apparent reason. So yeah, so you can have tactile hallucinations as well.
Fantastic. Well, I know we are basically out of time, and this was very helpful. I know we didn't get to all of the questions. We could probably spend another hour discussing this. I know there were things in your slides that you didn't get to because of time. So we'll just have to invite you back. But honestly, it's really good to just continue to review and discuss all of the different things. Everyone's experiences are different. Like Dr. Friedman said, it's a conversation to have with your physician, to talk through them. But the more you understand what might be outside of the norm is helpful. And just a little teaser for this week in our programs. It's a branded talk that we're going to be discussing Parkinson's disease psychosis and a treatment. So it'll go into a little more of the treatment of some of the things that Dr. Friedman was talking about today. So if you want to join us for that, that will give you that perspective. But I want to thank Dr. Friedman so much for joining us and giving us this great presentation. And I will let you know he does have a couple of books available. One is Making the Connection Between Brain and Behavior. I know you can get that on Amazon. He also has a free book download. I can't remember what the title of that book is though.
Well, free guide to Parkinson's disease.
Yes.
Free
So
guide to Parkinson's, and it's free. No sign up, no advertisements, no, nothing. Just you put that into Google and you should be able to get the book.
yes, and if it's free, it's for me. So it's really good information. So please take advantage of those two resources. And so now in PMD Alliance style, we want to thank you, Dr. Friedman, for your time and your expertise. So I'm going to invite everybody to show their appreciation, give you the wave of gratitude from all across the United States, maybe even beyond. And thank you for your time today.
Thank you all for listening and thank you for the invitation. Take care.
Yeah, everybody have a great day.